Hello class and welcome to today's lecture on Chapter 24 of your Understanding Medical Surgical Nursing book published by F.A. Davis. This chapter will cover nursing care of patients with occlusive cardiovascular disorders. I recommend that as we go through the slides, take notes on your printed slides and keep your book handy. My goal for this lecture will be to explain the etiology, signs, symptoms, and therapeutic measures of coronary artery disease, angina pectoris, and myocardial infarction. List data to collect for patients with coronary artery disease, angina pectoris, or myocardial infarction. We will also describe therapeutic measures used to treat coronary artery disease, angina pectoris, and myocardial infarction. We will also explain the etiologies, signs, symptoms for each of the peripheral vascular disorders, identify therapeutic measures used to treat peripheral vascular disorders, plan nursing care for patients with a peripheral vascular disorder. First and foremost, we need to discuss cardiovascular disease, which is abbreviated CVD. Cardiovascular disease is the leading cause of disability and death in the United States. It affects all aspects of someone's activities of daily living and their quality of life. Most of the time, there are risk factors that we consider modifiable that lead to cardiovascular disease. Since these factors are modifiable, education is one of the most important tools available for healthcare providers, including nurses, to use. Cardiovascular disease is very common. Currently, as of the publishing of this text, there are 92.1 million people suffering from cardiovascular disease. An average of 2,200 people pass away each day due to the disease process. The greatest incidence of people are those over the age of 65 and men more than women. The first condition that we will talk about is arteriosclerosis. Arteriosclerosis is a thickening, calcification, and loss of elasticity of the arteries. This is considered part of the aging process as the inner lining of the artery begins to lose elasticity and begins to weaken. Remember that the arteries are under very high pressure from the force of contraction. Next, we need to discuss atherosclerosis. Atherosclerosis is a type of arteriosclerosis. This is characterized by the formation of plaque in the arteries. These can begin in early childhood and progress without symptoms well into adulthood. Atherosclerosis is the cause of coronary artery disease, which is abbreviated CAD. The pathophysiology of atherosclerosis is one that has multiple steps, all of which affect the inner lining of the artery. Injury and its resulting inflammation to the artery endothelial cell linings causes the immune system to activate and bring white blood cells to the damaged area. This damage to the smooth muscle cells stimulates growth of new smooth cells, and these cells secrete collagen and fibrinous proteins. With the triggered immune system and new cell growth, lipids, platelets, and clotting factors accumulate, narrowing arteries. Furthermore, scar tissue replaces some of the arterial wall as the accumulated collagen and platelets settle in. Early in the pathophysiology, an indication is a fatty streak on the lining of the artery. This buildup or fat deposits is what we call in the medical profession plaque. Plaque is made up of smooth muscle cells, fibrinous proteins, and cholesterol-laden cells. This plaque has irregular and jagged edges, and this is important clinically because blood cells and other blood materials adhere to those edges as they become stuck. This plaque also then creates a firm shell that contains calcium around it. Now it is known as calcified plaque. What this ultimately does is narrow the artery, reducing blood flow to anything distal where the narrowing occurs. Also important to note is that the jagged edges create turbulent blood flow in the arteries, leading to damage of healthy cells in the bloodstream and further increases the accumulation of cells and fibrinous proteins. In addition to the narrowing of the arteries, reducing blood flow to anything distal of the site is the fact that this plaque may rupture or tear and become embolic in nature. These plaque emboli can travel to the coronary arteries and become lodged distally, causing a myocardial infarction. So as we talked about, the pathophysiology contains multiple steps, each contributing overall to the narrowing of the arteries and potential for plaque to become embolic. So who is at risk for atherosclerosis? There are many factors to be considered, and we need to understand something here. There are two types of risk factors for this disease process. Ones we consider modifiable and non-modifiable. Non-modifiable risk factors are things that a person has absolutely no control over. For instance, age. This disease process can be part of aging process. A person cannot control how old they are, so we consider this as a non-modifiable risk factor. Gender. Men are more predisposed to this disease process than women, and a person cannot control what gender they are assigned at birth. Ethnicity. African Americans have a higher incidence of atherosclerosis, and this is something a person has no control over. Excessive alcohol intake raises blood pressure, increases triglycerides, and causes irregular heartbeats. Obesity increases heart workload and increases the risk for hypertension, diabetes mellitus, glucose control, and hyperlipidemia. Sedentary lifestyle increases obesity, hypertension, and hyperlipidemia. Emotional stress can increase heart workload and risk for hypertension. Tobacco use and even secondhand smoking leads to vasoconstriction, increases myocardial oxygen demand, and decreases HDLs. Homocysteine. When this interacts with vitamin B12s, it changes to essential amino acid and non-essential amino acids. Deficiencies in vitamin B family can lead to excessive homocysteine in the blood levels, which may damage the lining of the arteries. So when we have a high level of homocysteine, that can lead to blood clots or blood vessel blockages, and then artery damage or blood clots significantly raise our risk of heart attack. Total cholesterol level above 200 increases the risk of CAD and MI. Elevated low-density lipoproteins and low levels of high-density lipoproteins are associated with increased risk for CAD. High levels of LP cholesterol is a risk factor for premature CAD. It is a genetic variation of plasma LDL. LDL particle number is an excellent predictor of MI risk. It is measured directly or indirectly as apolipoprotein B. Apolipoprotein B is a protein particle in each LDL and can penetrate the arterial walls, causing damage. Apolipoprotein A is a protein component of HDL. CRP is an indicator of low-grade inflammation in coronary arteries. Elevated blood glucose levels can also increase the risk of atherosclerosis. Radiological studies of the arteries can be performed to show narrowed or occluded vessels. Therapeutic interventions for atherosclerosis include eating heart-healthy diet, not smoking, exercising, and taking lipid-lowering agents. CAD is the obstruction of blood flow through the coronary arteries to the heart muscles, typically from atherosclerosis. This can lead to angina, myocardial infarction, and sudden death. We talked about the risk factors in the earlier slide. Low-dose aspirin may be prescribed by a healthcare provider for certain patients to prevent the formation of a thrombus. Angina pectoris is chest pain due to ischemia resulting from a reduction in coronary artery blood flow and oxygen delivery to the heart muscle. Angina is a symptom, not a disease, can be relieved by resting and using nitroglycerin. Angina pectoris is caused by narrowed blood vessels that are unable to dilate. Thus, they carry less blood and oxygen to heart muscle. Less oxygen causes myocardial ischemia, and this is very painful. So the first type of angina is stable angina. This occurs with moderate exertion and familiar pattern, usually stops with rest and nitroglycerin, and the pain is predictable. Another type of angina is unstable angina. Pain is unpredictable, occurs with less exertion at rest during sleep. unrelieved with rest or nitroglycerin. And the cause could be blood clots reducing blood flow. This can lead to MI. Variant or vasospastic angina is caused by coronary artery spasms and is serious. It often occurs in cyclical pattern, that is, the pain occurs around the same time each day. The pain lasts longer than stable angina, can occur at rest or with exercise, often occurs at night. Microvascular angina is caused by spasms in the walls of the tiniest arteries of the heart that reduces coronary blood flow. Pain may be more severe and last longer. Anginal chest pain may be described as discomfort, burning, fullness, heaviness, pressure, or squeezing. Pain may radiate down one or both arms, left arm is common, or into the shoulder, neck, jaw, or back. Patients may complain of heaviness in arms or feeling of impending doom. They may be pale, diaphoretic, or dyspneic. Some atypical signs and symptoms may develop in women, along with the chest pain, jaw pain, and heartburn. These atypical symptoms may be described less severe pain, fatigue, nausea, and breathlessness. The diagnostic tests that can help us determine angina can be electrocardiogram or ECG, exercise ECG or stress test, echocardiography, chemical stress testing, cardiac computed tomography scan or the CT scan, cardiac magnetic resonance imaging or angiogram, MRI or MRA, radioisotope imaging, or coronary angiography. Our goals for angina would be to identify risk factors. Therapeutic interventions could include weight reduction, heart-healthy diet, and emotional stress reduction. Three main groups of medications used for relieving angina are vasodilators, that is nitrates, calcium channel blockers, and beta blockers. In vasodilators, nitroglycerin is the drug of choice for actual angina attacks. Nitrates dilate coronary arteries to increase oxygen to the myocardium and dilate peripheral vessels, so the heart does not have to work so hard to pump blood into them. This can be administered orally, sublingually, transdermally, intravenously, or as a lingual spray. Sublingual administration may relieve chest pain within 1 to 2 minutes. What do you think we need to watch for when administering vasodilators? What medications should be avoided in these patients? So, for meds for erectile dysfunction, for example, Viagra, they dilate blood vessels and may cause a drop in blood pressure, so we should avoid those. We should not be giving nitroglycerin to somebody who's taken Viagra recently. Long-acting nitrates can be administered to prevent chest pain, oral ointment or transdermal patches. We can remove those patches at bedtime and apply them in the daytime. A side effect is headache, which is relieved by aspirin. What do you think we need to watch for when applying the transdermal patches or ointments? Beta blockers decrease heart rate, lower blood pressure, and prevent release of renin. They reduce the workload of the heart to prevent anginal attacks. Use with caution in patients with heart failure because they can worsen their effects. Selective and non-selective types of beta-adrenergic blockers are used. People with asthma or COPD should avoid non-selective because they can cause bronchoconstriction. These patients can use metoprolol and atenolol as they are cardioselective. Beta blockers should not be used for coronary artery spasms or variant angina. Recognize beta blockers by the generic names ending in olol. Angiotensin-converting enzyme inhibitors or ACE inhibitors block production of angiotensin II, which is a potent vasoconstrictor. As a result, we get vasodilation and lower blood pressure. They may cause retention of potassium in some patients. If a patient taking ACE inhibitors develops a dry cough, inform the healthcare provider so medication can be changed. Recognize the ACE inhibitors by the names ending in pril. Next, we'll talk about statins. Cholesterol and inflammation in artery walls are involved in atherosclerosis development. Statins lower cholesterol levels by reducing cholesterol production in the liver, reduce inflammation and CRP levels. They are used to prevent and treat atherosclerosis. Antiplatelets can prevent cardiovascular events. Some nursing diagnoses for CAD and angina include acute pain and deficient knowledge. Please refer to your book for complete nursing care plan. For the acute pain diagnosis, ensure IV access for drug administration, rate their pain using a suitable pain scale, administer oxygen, administer nitroglycerin as prescribed, administer aspirin as prescribed, administer morphine as prescribed, remain with the patient, and provide emotional support. For the nursing diagnosis of deficient knowledge, determine readiness to learn, include significant other in teaching, use appropriate teaching tools and interpreter as needed, identify patients' learning needs, explain CAD pathophysiology, risk factors, management, and medications, identify community resources for lifestyle changes, and document teachings and evaluation of understanding. Acute coronary syndrome includes the conditions of unstable angina and myocardial infarction. It is caused by a sequence of inflammatory processes leading to thrombus formation and reduced blood flow, unstable angina, or to partial or complete coronary artery occlusion, which is the myocardial infarction. Silent ischemia is the ischemia that can go undetected. It's a great risk. This can lead to myocardial infarction without chest pain, often seen in older adults and seen with hypertension and diabetes. Sudden cardiac death can result from cardiac arrest, which is triggered by lethal ventricular arrhythmias, or asystole from an abrupt occlusion of coronary artery. Prompt treatment is required in attempt to prevent death. Myocardial infarction results in the death of the heart muscle. It occurs from partial or complete blockage of a coronary artery. Ischemic injury evolves over several hours before complete necrosis and infarction takes place. The cells of the heart in the area that is supplied by the blocked artery do not receive blood and die. The extent of the cardiac damage depends on the location and amount of blockage in the coronary artery. The cellular death may not occur with timely and effective reperfusion. Non-ST segment elevation MI or STEMI is caused by partial blockage. ST segment elevation MI or STEMI is caused by complete blockage. In this image, you can see myocardial infarction, areas of ischemia, injury, and necrosis caused by a blockage in the left anterior coronary artery. Prolonged ischemia can produce severe cellular damage and necrosis of cardiac muscle. Once necrosis occurs, the contractility of the muscle is permanently damaged. The heart has a zone of ischemia and injury around the necrotic area. The zone of injury is next to the necrotic area. It is susceptible to becoming necrosed. If we initiate treatment within the first hour of MI and restore blood supply, then the area of damage can be minimized. The area of ischemia and viable tissue surround the area of injury. If the heart responds to treatment, this area can be rebuilt and develop collateral circulation. Poor ischemia may lead to larger infarction. In this image, you can see the anterior and posterior view of the heart showing us the coronary arteries. Left coronary artery supplies the anterior wall of the heart, including most of the left ventricle. Right coronary artery supplies the heart's inferior walls and parts of AV node and SA node. Left circumflex coronary artery supplies the heart's lateral wall and part of the posterior wall. So what are the signs and symptoms of MI? Chest pain is a classic symptom. It begins suddenly and is not relieved by rest or nitroglycerin. The pain can be described as crushing or vise-like or as if an elephant is standing on the chest. It can radiate to back, one or both arms and shoulders, neck, or jaw. Pain can imitate indigestion or a gallbladder attack with abdominal pain and vomiting. Shortness of breath, dizziness, nausea, and sweating may be also described by the patients. The heart rate is increased and is usually an irregular rhythm. In patients with heart failure, S3 or S4 may be present, indicating myocardium is failing. When we auscultate the lung sounds, we may hear crackles or wheezing with heart failure. Educate the individuals, especially women, that time is muscle. That is, as the time goes by without interventions during myocardial infarction, more muscle is lost or damaged. Heart disease is still the leading cause of death in women in the US. African American women are more likely to develop heart disease than Caucasian women. Women tend to have acute MIs at an older age when compared with men. They also have a higher mortality rate and more complications such as VFib and heart failure. Many women report having noted prodromal symptoms a month before an acute MI, including unusual fatigue, sleep disturbances, and shortness of breath. Typically, women often fail to recognize or deny the symptoms and wait to seek care. In addition to chest pain, women may also report atypical symptoms such as extreme fatigue, epigastric pain, jaw pain, indigestion, nausea and vomiting, dyspnea, shortness of breath, or cramping in the chest. Some other atypical signs and symptoms for women or older adults may include absence of classic pain, dyspnea, fatigue, anxiety, chest cramping, epigastric or abdominal pain, restlessness, and falling. Older adults should be educated to report to healthcare provider if they experience any shortness of breath, fatigue, fast or slow heartbeats, or chest discomfort. They may have silent MIs. Collateral circulation may offer protection. Reperfusion therapies such as angioplasty and bypass surgery seem to be superior in improving quality of life. For the patient to be diagnosed with MI, consider the patient's history. Also, diagnostic tests such as ECG, levels of serum cardiac troponin I or T, myoglobin, and creatinine kinase CKMB can be completed. ECG typically shows the areas of infarction as well as ischemia. Serial ECGs monitor changes indicating damage or ischemia. Check magnesium and potassium levels as both are essential for a normal cardiac function, especially during diuretic therapy. On an ECG, myocardial damage can be seen as an ST segment elevation, the presence of a Q wave or T wave abnormalities. Figure A shows ST segment elevation. Figure B shows ischemia, ST segment inversion. Figure C shows necrosis, large Q wave, and ST segment elevation. We will be going over the ECG readings later on in another chapter. Ideally, medical treatment should be sought within 5 minutes for unrelieved chest pain. American Heart Association recommends chewing 1 uncoated adult aspirin at the onset of chest pain as directed by a healthcare provider. Goal is to restore the blood flow to the heart muscle within 90 minutes or less of the patient's arrival at the ED door. Therapeutic interventions for acute MI may include administration of oxygen, which is typically administered via nasal cannula at 2 liters per minute rate. It may be limited to the first 6 hours in stable patients. We should be monitoring pulse ox to stay above 94%. We should monitor arterial blood gases or ABGs for accurate oxygen concentration needs. Aspirin is an antiplatelet that inhibits platelet activation, adhesion, or procoagulant activity. Bleeding or bruising could be a concern with administration. Antiplatelet therapy may be a long-term intervention after an MI. Analgesics such as morphine sulfate can be used to relieve chest pain, typically given in the increments of 2 to 8 milligram IV every 5 to 15 minutes until pain is relieved. Monitor for hypotension, respiratory depression, oversedation, and morphine sensitivity. The preload, afterload, and anxiety is relieved. Thrombolytic therapy aims to dissolve a blood clot that is occluding a coronary artery. It should be administered within 1 to 6 hours before the necrosis results. Goal is to administer within 30 minutes of arrival in ED. Nitroglycerin can be administered sublingually, topically, or by IV drip for vasodilation to supply more blood to the myocardium to reduce pain and the workload of the heart. It should not be administered if the patient's systolic pressure of less than 90 millimeters of mercury or 30 millimeters of mercury or more below baseline, or severe bradycardia less than 50 beats per minute, or has taken a phosphodiesterase inhibitor for erectile dysfunction. Beta blockers decrease pulse, blood pressure, cardiac output, and suppress renin activity. Decrease the risk of sudden death. Contraindicated in asthma, heart block, and bronchoconstriction. If BP is less than 90 millimeters of mercury and pulse is less than 60 beats per minute, notify healthcare provider before medication administration. Antiarrhythmias inhibit ventricular arrhythmias. An example is amiodarone. It can be is contraindicated in AV block or pregnancy. For these patients, we would monitor vitals and ECG. Avoid grape juice with oral administration. Percutaneous coronary intervention, or PCI, uses a small balloon to increase blood flow and oxygen to the myocardium. Emergency PCI is frequently used for acute MI. It should be initiated within 90 minutes. In a cardiac cath lab, a catheter with balloon tip is inserted, usually via femoral or radial artery, advanced into the heart to open the blocked coronary artery. Once the blocked artery is entered, the balloon on the catheter is inflated and atherosclerotic plaque is compressed. This can be done with or without stent placement. Coronary artery stent can prevent closure of the coronary artery from an atherosclerotic lesion. Stent is an expandable metal mesh tube that is implanted at the area of stenosis to keep the blood flowing through the artery. Some other interventions include bed rest and bedside commode to reduce myocardial oxygen demand and straining in the initial days following an MI. Intra-aortic balloon pump may be used to increase circulation to the coronary arteries and reduce the work of the heart. Diet is gradually progressed to optimal level of tolerance. Avoid caffeine as it is a stimulant and causes vasoconstriction. Diet and weight loss plans can be initiated to assist the patient and family with management post-MI. Dietitians can help with this immensely and should be contacted as directed. Smoking cessation programs should be incorporated into post-management as required, and patient education should include hazards of smoking and/or exposure to second-hand and third-hand smoke. We talked about aspirin as an antiplatelet earlier. Some other antiplatelets include Plavix, Brilinta, and Effient. Statins are the first-line drugs to reduce low-density lipoprotein (LDL) by reducing cholesterol synthesis. Some common statins are atorvastatin, Lipitor, rosuvastatin, Crestor, and simvastatin, Zocor. Monitor liver functions and signs and symptoms of rhabdomyolysis. Typically, patients are taught to take the medication in the evening and report muscle pain to healthcare provider. We learned about ACE inhibitors earlier. They block the production of angiotensin II, a potent vasoconstrictor. They improve vasodilation, cardiac output, and exercise tolerance. They can be recognized by the ending pril. Examples are lisinopril, Zestril, and which is also known as Zestril, and enalapril, Vasotec. Monitor vitals and adhere to blood pressure and pulse parameters as ordered. We had also briefly discussed beta blockers in the previous slides. Check out the table 24.3, 24.4, and 24.7 in your books for further details on these drug classes. AHA guidelines can help determine if the patient will benefit from PCI or coronary bypass graft, or commonly known as CABG. The saphenous vein from the leg or an internal memory artery from the chest wall is used to reroute the blood around a segment of coronary artery that is narrowed by atherosclerosis. In this figure, we can see retrieval of a saphenous vein from the leg and its use in CABG for myocardial reperfusion. There are two types of bypass procedures, arrested heart surgery and beating heart surgery. Most bypass surgeries are done by stopping the heart and using cardiopulmonary bypass machine or on pump, that is arrested heart surgery. The median sternotomy and the retrieval of vein graft is typically done simultaneously. The graft is flushed with heparinized solution to check for leaks and then set aside for use during the surgery. During surgery, one end of the vein is joined to the coronary artery distal to the occlusion while the proximal end is often joined to the ascending aorta. Beating heart surgery is done with the heart beating and does not require the cardiopulmonary bypass machine, that is, it's done off pump. A device is used to stabilize a vessel while the surgeon works on it. Either traditional median sternotomy or minimal invasive surgery can be used. Less invasive procedures are minimally invasive coronary bypass grafting and totally endoscopic or coronary bypass surgery. Minimally invasive coronary bypass grafting is done off pump and involves a small fifth intercostal incision. Totally endoscopic coronary bypass surgery can be done on or off pump and uses 3 or 4 chest holes for insertion of robotic arms and a camera that a surgeon then uses to control the robotic arms. Some of the applicable nursing diagnoses for patients with MI are acute pain, decreased cardiac output, fear, and activity intolerance. Please refer to pages 419 to 421 in your books for a nursing care plan for patients with MI. Some applicable nursing diagnoses for patients undergoing cardiac surgery are acute pain, decreased cardiac output, and risk for infection. Please refer to pages 421 and 422 in your books for nursing care plan for patients undergoing cardiac surgery. Nursing care for these patients involves monitor vital signs, monitor for arrhythmias, report symptoms, provide incisional care, and monitor for depression. Patients will require education on disease information, medications, diet, activity and exercise, rehabilitation, and stress reduction. Cardiac rehabilitation can be initiated when the patient's acute symptoms are relieved to improve cardiac function and quality of life. Phase 1 begins in the hospital with specific protocols for activities for each day. Phase 2 occurs 4 to 6 weeks post-discharge in an outpatient program. The focus is on returning the patients to previous levels of activity and function. Phase 3 follows, during which patients are encouraged to maintain optimal fitness and continue healthy lifestyles. Next, we are going to talk about peripheral vascular disease, or PVD. PVD may be either arterial or venous. It's common in older adults and diabetics. It's imperative to determine the origin of disease as that guides the correct treatment to prevent complications. Acute arterial occlusions are often sudden and dramatic. Occlusions are most common in the lower extremity but may occur in upper extremity as well. A thrombus or clot adheres to the vessel wall. Acute arterial thrombi have many causes, including injury to the wall, sluggish flow, plaque formation, polycythemia, dehydration, and repeated arterial needle sticks. When a thrombus breaks off and travels, it becomes an embolism that can occlude an arterial vessel that is too small to allow it to pass. Some causes of an arterial embolism are arrhythmias, prosthetic heart valves, MI, and rheumatic heart disease. Usually, the onset of symptoms is abrupt with acute arterial occlusion, unless collateral circulation has developed that is able to supply some blood to the occluded areas. Symptoms depend on the artery occluded, tissue supplied by the artery, and presence of the collateral circulation. Typically, there will be decreased movement in the affected extremity. The extremity may be pale, mottled, and without pulses distally to the occlusion. It could also feel cool to. Clinical signs of acute artery occlusion are known as the 6 Ps, that is pain, pallor, pulselessness, paresthesia or numbness, paralysis, and poikilothermia, which is when it assumes environmental temperature. Immediate treatment is needed to save the affected extremity. Anticoagulant therapy, usually with IV unfractioned heparin or UFH, is initiated to prevent further clotting. This treatment does not affect existing clots. Therapy may continue for several days. The levels are monitored with activated partial prothrombin time or APTT or anti-factor XA. After 3 to 7 days, an oral anticoagulant such as warfarin, also known as Coumadin, or a low molecular weight heparin, LMWH, is started. Warfarin takes 3 to 5 days to reach therapeutic levels. UFH is continued until warfarin reaches therapeutic levels, unless LMWH is being used for bridging. Warfarin levels are monitored by international normalized ratios or INRs. Daily changes in warfarin doses are made to reach therapeutic levels. Enoxaspirin or Lovenox is an example of low molecular weight heparin. Low molecular weight heparins often require no lab monitoring. In severe cases, surgery or thrombolytic agents are used to save the extremity. Thrombolytic agents dissolve a thrombus or embolus. Embolectomy or thrombectomy involve cutting the artery open, removing the clot, and suturing the vessel close. Peripheral arterial disease, or PAD, is a disorder of the arterial circulation usually caused by chronic progressive narrowing of arterial vessels that leads to obstruction or occlusion. Usually affects the lower extremities. Sometimes it's referred to as the lower extremity arterial disease or LEAD. PAD can be organic or functional. Organic PAD is caused by structural changes from plaque or inflammation in the blood vessels. Functional disease is a short-term localized spasm in the blood vessels as occurs in Raynaud's disease. Arterial system functions to deliver oxygen-rich blood to the vascular beds. Anything that impedes the flow can cause an imbalance in the supply and demand for oxygen. Other mechanisms in the body attempt to compensate for the reduced blood flow, such as peripheral vasodilation, anaerobic metabolism, and development of collateral circulation. However, these mechanisms are not intended to meet the body's ongoing supply needs. Eventually, the lack of blood supply gives rise to signs of ischemia, which, if left untreated, results in ulceration, gangrene, and necrosis. Amputation of the extremity may become necessary. Many people may not have any symptoms until later in the disease, when there are changes in the extremities related to diminished blood flow. We may observe hair loss on lower calf, ankle, and foot, along with dry, flaky, scaly, mottled, or pale skin. Toenails may be thickened. Pain in the calves associated with activity or exercise is called intermittent claudication, which is a common symptom of arterial occlusive disease. Muscle cramping results from ischemia related to decreased supply of oxygen-rich blood to the muscles. Pain stops when activity is aborted. However, as PAD progresses, the pain may occur even at rest, indicating severe arterial occlusion. The lower extremity is typically pale when elevated and is reddish purple or cyanotic when dependent. It can be cool to touch with diminished or absent pulses. Some diagnostic tests for PAD include ankle brachial index, which compares the blood pressures in the upper and lower extremities. Normal findings include higher blood pressures in the calf and thigh compared to upper extremities. In PAD, this is reversed. Normally, the ankle blood pressure is equal to the brachial blood pressure. However, with an occlusion, the blood pressures become unequal. A duplex ultrasound measures the velocity of blood flow. MRI and CT scans can give definitive images of blood vessels and degrees of arterial occlusion. Plethysmography and angiography can be used to evaluate arterial flow in lower extremities. For mild to moderate occlusive disease, including those with intermittent claudication relieved by rest, conservative treatment is initiated. Regimen includes medication for vasodilation and diet management. Statins are used to decrease cholesterol and lipid levels. Antiplatelet agents such as aspirin and Plavix are used to prevent blood clots. Platel treats claudication to improve walking ability. Percutaneous transluminal angioplasty, abbreviated as PTA, can be used to dilate a narrowed peripheral vessel. It does not provide long-term results. It is similar to PCI. Peripheral atherectomy is used to remove plaque from atherosclerotic arteries. Intravascular stents can be used to maintain patency of the artery. Platelet aggregation inhibitors are given to prevent blood clots in these cases. Vascular bypass involves the use of either autografts, that is, patient's own saphenous vein, or a synthetic graft material. The graft is anastomosed or joined to the artery proximal to the occlusion and tunneled past the occlusion. There, the distal end of the graft is anastomosed to the artery. The graft is assessed for hemostasis and function. The wound is then sutured closed. In this figure, we can see the aortofemoral bypass. Some of the nursing diagnoses for PAD are ineffective tissue perfusion, acute pain, activity intolerance, and readiness for enhanced health literacy. Check out the nursing care plan for patients with PAD in your books on pages 426 and 427. Raynaud's disease is a local overreaction by the blood vessels that results in vasospasm, primarily in the digits when exposed to cold or emotional stress. The abnormal vasoconstriction in the small arteries in the digits reduces arterial blood flow. This can also affect ears, nose, and lips. Primarily, Raynaud's disease does not occur due to another disorder. Secondary Raynaud's disease may be seen with collagen diseases such as rheumatoid arthritis, scleroderma, systemic lupus erythematosus, and endocrine disorders. Women who live in cold climates are more often affected. The affected area of skin may turn white and then blue with reports of coldness and numbness. With warming, pain, tingling, and redness, hyperemia occurs. Normal blood flow returns in about 15 minutes. Initial therapy goals are to improve quality of life and prevent injury to the tissue from ischemia. Educate patients on avoiding cold and wearing gloves outdoors when they're cleaning a refrigerator or preparing cold foods. Avoid smoking, alcohol, caffeine, and emotional stress. Immersing hands in warm water may decrease vasospasm. Calcium channel blockers may be prescribed to prevent vasoconstriction. Thromboangiitis obliterans, or Buerger disease, is a rare recurring inflammation and thrombosis of small and medium arteries and veins in the limbs. The cause is unknown, but it may be autoimmune. It is associated with all types of tobacco use, so to stop its progression, all tobacco use must be avoided. Periodontal disease may be a factor in the development of the disease. Signs and symptoms of Buerger disease may include intermittent claudication, vein inflammation, numbness and pale digits with cold exposure. Distal extremity ischemia can lead to ulceration, gangrene, and amputation. Unfortunately, for Buerger disease, there is no cure, so it is imperative that we teach patients to stop smoking. Treatments such as platelet inhibitors and vasodilators are less effective. The goal is to reduce complications of ulceration, gangrene, and amputation. Next, we will be learning about aneurysms. An aneurysm is a bulging, ballooning, or dilation at a weakened point of an arterial wall. Artery diameter is often increased by 50%. Risk factors include atherosclerosis, hypertension, smoking, trauma, and congenital abnormalities. Heredity may be a risk factor as well. Abdominal aortic aneurysm is the most common aneurysm, and that's going to be the focal point of discussion here. Abdominal aortic aneurysm is typically silent if it is less than 4 cm, and its incidence increases with age. There are 3 types of aneurysms. Fusiform is an aneurysm in which the entire artery circumference is dilated. Saccular is a one-sided dilated artery. In the dissecting type of aneurysm, a tear in the inner layer causes a cavity to form between the layers of the artery and fill with blood. The cavity expands with each heartbeat. In this figure, you can see the types of aneurysms. The first image is fusiform. The entire circumference of the artery is dilated. The second one is the saccular. One side of the artery is dilated. And the third one is dissecting. A tear in the inner layer causes a cavity to form between the layers of the artery and fill with blood. The cavity expands with each heartbeat. There are few, if any, signs and symptoms until the abdominal aortic aneurysm grows. Back or flank pain is the classic symptom caused by the aneurysm pressing against the nerves of the vertebrae. Feeling of fullness or nausea may be caused by the aneurysm pressing on the intestines. Pulsating mass in the abdomen is typically discovered during routine physical or X-ray exams. Severe sudden back pain or abdominal pain or flank pain and a pulsating mass, abdominal mass may indicate that aneurysm may rupture. Shock may develop if abdominal aortic aneurysm ruptures, and this needs immediate surgery. Diagnostic tests for aneurysms include abdominal ultrasound, CT scan, MRA, and aortography. Small aneurysms that are less than 4 centimeters are monitored for enlargement with ultrasound about every 6 to 12 months. Medical treatment includes smoking cessation, gentle exercise such as walking and bike riding, avoiding the lifting of heavy objects, blood pressure control to prevent arterial wall rupture, and beta blockers to slow abdominal aortic aneurysm enlargement. Surgical repair or bypass graft is performed for pain, signs of circulatory compromise, and an aneurysm that is larger than 5.5 centimeters or rapidly enlarging. Open surgical repair or an endovascular stent graft may be done to repair the AAA. Nursing diagnoses for patients with aneurysm include acute pain and ineffective tissue perfusion. Nursing care includes patient education on understanding their medication regimen, avoiding lifting, and reducing stress preoperatively and postoperatively. Now we are going to learn about varicose veins. Varicose veins are elongated, tortuous, dilated veins. The cause is unknown, however, we think the heredity is involved. There are two types of varicosities, primary and secondary. Primary varicosities are caused by a structural defect in the vessel wall. Dilation of vessels can lead to incompetent venous valves, which can disrupt blood flow and induce reflux. This in turn leads to further dilation and blood pooling in the lower extremities. Superficial veins are more often involved in primary varicosities. Secondary varicosities are caused by an acquired or congenital pathological condition of the deep venous system. This produces dilation of the collateral and superficial veins. Again, this disrupts blood return and leads to stasis or pooling of blood in the deep vein system. This increases the pressure in the system, pushing blood into the collateral vessels and producing varicosities in the superficial veins. Wall defects have been identified as having familial tendency. Any factor that contributes to increasing hydrostatic pressure within the leg, such as prolonged standing, pregnancy, and obesity, can promote venous dilation. Signs and symptoms of varicose veins include telangiectasias, or commonly known as spider veins, dull pain, cramping, edema, heavy feeling in lower extremities, ulceration, and disfigurement of lower extremity. Therapeutic interventions include reducing contributing factors, relieving pain, elevation and exercise, compression stockings, injection sclerotherapy, radiofrequency ablation, laser, and vein stripping. Injection sclerotherapy to collapse vein and laser or light therapy can treat superficial varicosities. Minimally invasive ablation to seal the veins include radiofrequency or laser ablation. It can be done in the healthcare provider's office with local anesthesia. Traditional vein stripping is done in surgery, although it's becoming rare. Next, we will discuss venous insufficiency, which is a chronic condition. Damaged or aging valves eventually lead to pooling of blood in the lower extremities and can cause venous stasis ulcers. Venous stasis ulcers are the end result of chronic venous insufficiency. Dysfunctional valves in the venous system prevent or reduce the venous blood return. With time, the congestion and decreased venous circulation lead to changes in the lower extremities. There may be edema and a brownish discoloration of the leg and foot, with the surrounding skin hardened and leathery in appearance. The brown color is caused by the rupturing veins releasing red blood cells into the tissue. The red blood cells then break down and stain the tissues brown. This is called hemosiderin staining. Stasis ulcers develop from the increased pressure and rupture of small veins. Signs of breakdown are most commonly seen at the medial malleolus of the ankle. These can be very difficult to cure and adversely affect a person's quality of life. The main goal is to decrease edema and heal skin ulcerations. Compression wraps such as stockings or bandage wraps are necessary to decrease edema. Bed rest and elevation of legs and feet above the heart are important to assist with venous drainage of lower extremities. Educate patients not to keep legs dependent and avoid long standing or sitting to prevent increased pressures and pain. Elevate foot of bed to 5 to 6 inches. Exercise and walk often during non-acute episodes. Patients should be educated not to cross their legs or wear constrictive clothing. Skin ulcers can be cultured and treated with topical antibiotics as needed. Wound care can be chronic and challenging. An Unaboot can promote healing in severe ulcers. It is a gauze dressing that's coated with zinc oxide, calamine, and glycerin. It can be changed every 2 to 7 days. Skin grafting may be necessary for severe or non-healing wounds. Some nursing diagnoses for venous disorders are acute pain, impaired tissue integrity, and ineffective health maintenance. Nursing interventions include wound care, emotional support, and education related to elevating legs, protecting legs from injury, not crossing legs or wearing tight clothes, avoiding heating devices, and applying compression from foot upward. Preoperative vascular nursing diagnoses include acute or chronic pain, anxiety, and deficient knowledge. When an artery becomes completely occluded by an embolus or thrombus, it is considered a surgical emergency. Surgical removal aims to restore blood flow and oxygenation to the tissue distal to the occlusion to decrease ischemia and necrosis. As discussed earlier, vascular bypass involves the use of either autografts. This is patient's own saphenous vein or a synthetic graft material. The graft is anastomosed or joined to the artery proximal to the occlusion and tunneled past the occlusion. There, the distal end of the graft is anastomosed to the artery. The graft is assessed for hemostasis and function. The wound is then sutured closed. Endarterectomy involves dissection of arteriosclerotic plaques from the inner lining of the arterial wall and remove them. Most commonly performed on carotid artery, but may be done on peripheral arterial vessels as well. The artery is clamped on both sides of the occlusion. An incision is made into the artery. Plaque is removed with forceps. The artery is irrigated to remove any further debris and then closed with sutures. The clamps are removed and the skin incision is closed. A drain may be placed to prevent hematoma formation. Minimally invasive techniques to open plaque-blocked arteries include balloon or laser angioplasty. A flexible laser-tipped catheter is inserted into the artery and advanced to the site of blockage. The laser sends out pulsating beams of light which vaporizes the plaque. The procedure is used for patients with smaller occlusions in the distal superficial femoral, proximal popliteal, and common iliac arteries. Stents are placed in the arteries to support the artery walls to keep them open. Some complications associated with vascular surgeries include bleeding and hemorrhage, fluid volume deficit, reocclusion, which is a surgical emergency, hematoma, and neurological dysfunction. If hemorrhage occurs, manual pressure is applied to the site of bleeding and the healthcare provider is notified. Fluid volume deficit may occur because of significant blood loss in extensive surgeries. Reocclusion is a surgical emergency and the blood flow needs to be reestablished within 4 to 6 hours to prevent risk of amputation of the extremity. Postoperative drainage can cause swelling and hematoma formation. Drains can be placed to avoid this. Postoperative therapeutic interventions include maintaining airway, frequent vital signs, neurological checks, neurovascular checks, incision care and drain care, fluid status, hourly intake and output, monitoring electrolytes. Increased girth may indicate bleeding. Some nursing diagnoses for post-op vascular patients can be acute pain, ineffective tissue perfusion, ineffective airway clearance, risk for infection, and deficient knowledge. We are going to touch briefly on lymphangitis. The lymphatic system returns the fluid from other tissues in the body to the bloodstream. It is a pumpless system with one-way valves that return fluid to the heart. Any interruption in the flow of lymph can result in edema. Lymphangitis is the inflammation of the lymphatic channels due to an infection. The infection can occur in the arms or the legs. It is commonly caused by the Streptococcus bacteria. Staphylococcus bacteria and others may also cause it. This is a serious infection that can cause sepsis and be fatal. Painful red streaks in the extremity, fever, chills, enlarged and painful lymph node are some of the signs and symptoms. Antibiotic therapy, moist heat, elevation, compression devices may help alleviate or reduce signs and symptoms. Nursing diagnoses for patients with lymphangitis include acute pain and risk for excess fluid volume. This brings us to the conclusion of this chapter. Please do not hesitate to contact if you have any questions. Thank you for listening.